EMDR, which is eye movement desensitization reprocessing. I was actually trained in EMDR back in 2008. It's a fairly extensive training program. I've not used it because I'm not practicing clinically right now, or since I'm being at Neomed, I'm not practicing clinically, but I had been using it when I was working in community mental health. So I'm going to give a little bit of an overview of the history and some of the technique, and then some of what we know about its efficacy. So EMDR is an approach to psychotherapy that was developed by Francine Shapiro back in the 1980s. It was an intervention, or is an intervention, focused on the traumatic memories and associated stress. So in 1987, she discovered that there were some effects of horizontal eye movements in desensitizing this discomfort associated with traumatic memories. In '89, she started to publish. And then in 1990, she started to discover that you could use other forms of bilateral stimulation. So the other forms would be bilateral tapping, or actually bilateral noises. So you could do clicks on either ear. With the eye stimulation, it's typically your eyes moving from, without moving your head, you're moving from one side to the other and following. I mean, you do this in sections of about 20 to 30 seconds per set. But it was, like I said, in '90 when she discovered that the tapping will also work, and as well as the noises. In 2008, there had been, at that point, over a dozen randomized controlled outcome studies of using EMDR for the treatment of post-traumatic stress disorder. What it showed is that for a range of anywhere between 3 and 6 sessions, you could get anywhere from 77% to 100% remission of PTSD symptoms when it was processing a single trauma. So a major car accident, something like that, but there being just one singular traumatic event. For a victim or a person who's suffered through multiple traumas, and there is efficacy around this with combat veterans, specifically, about 12 sessions or more were typically needed to remit symptoms for multiple traumas. Looking at it longitudinally, it showed equal effects when measuring overt symptoms of PTSD of EMDR compared to exposure therapies. EMDR is based on an adaptive processing model. So what Shapiro was looking at is that there's multiple components of every memory. You have your sensory input, you have thoughts, emotions, and beliefs that are all tied to any memory. And in most individuals, in most cases, disturbing events with an emotional trauma are adaptively resolved, and those memories can exist without having some maladaptive current process. Any disruption in that adaptive information processing system prevents these events from being adaptively resolved and stored. So what you have is information within that memory that is maladaptive and dysfunctional in the present time. Memory networks are the collection of memories with similar information that start to form the basis of our perceptions, attitudes, behaviors. So if you have an early childhood trauma, you end up having multiple memory networks that are connected to the early trauma that start to form some of our even self-cognitions. And maladaptive memory networks are thought to be the basis of pathology in the EMDR model. So as an approach to psychotherapy, there's a couple major components. One of the things is that you're really looking at an evaluation of the basic aspects of traumatic memories. So if there's a particular single trauma, then you would be looking at what are all of the pieces, the sensory inputs, the thoughts, beliefs around that traumatic memory. When there's multiple instances, or an early childhood instance, you would be looking for touchstone events. So this might be an early memory somewhere from childhood, or in the case of combat veterans, what was maybe the most significant traumatic memory. Memory networks are, like I said, those linked, connected memories that all have some similar information. Nodes would be the targeted disturbing memories. So if there are multiple disturbing memories, and those are the memories that you would focus on. The beliefs and cognitions that are tied to maladaptive memories, often these maladaptive memories have produced some kind of negative self-belief. So if it's child abuse, then developing some self-belief about not being worthy, or not being safe, or not being strong. And this belief is viewed as a verbalization of the stored affect. So in the EMDR approach, the belief is a symptom of pathology, not the cause of what's going on now. So the negative self-belief isn't the cause of how you feel, but it is a symptom of how your brain has processed and stored this memory and the information. So in adaptive information processing, we're asking patients to access the maladaptive memory. We're stimulating information processing with bilateral stimulation. And the goal is to move to an adaptive resolution, which includes a new positive emotional and cognitive framework. So EMDR activated reprocessing is as perceptions of the present, so our present day linked to memory networks, whether that's smells or situations, things that make us think about and bring back old memories of trauma. Those manifestations of the maladaptively stored memories are now experienced. So we have increased intense emotions in the present that is really connected to something farther in the past. These maladaptively stored memory networks and channels often can be helped to transmute into adaptive resolutions through EMDR activated reprocessing. And this reprocessing includes desensitization and developing new insights and changes in emotional and physical responses. So we're theoretically slowing down the train. And on each stop, as the train slows down, we allow for adaptive linkage to new networks. There are 8 phases in the basic protocol. The first phase is developing history, identifying some of the target memories, what are the core negative beliefs associated with those memories, preparation, and this is a huge piece of this. And when EMDR isn't as successful, it's because not enough time has been spent in the preparation phase. But preparation is really teaching stress management skills, self-calming techniques. Calm, safe place is one of them. I found that to be difficult with people with multiple traumas, where instead of using kind of a light stream guided visualization, calming techniques seem to be more effective for them personally. And fostering skills that help with self-mastery and calming themselves down in between sessions. And sometimes in the middle of a session when they got to a particularly challenging piece of a memory. Assessment to this was getting all of the details about a particular image with the negative self-beliefs, what the desired positive belief that they would like to replace this negative self-belief with would be. So instead of I'm not safe, replacing it with I am safe. I can choose to make myself safe. I can take actions that allow myself to be safe. Current emotions, current physical sensations, and baseline rating. There's 2 baseline rating measures that are used in EMDR. One is the subjective unit of disturbance or distress. So when you think about this old memory, when you picture this, how much distress do you feel? 0 to 10. And the goal is to get as close to 0 as possible. And then the validity of a positive cognition. So when you're in the beginning phases of treatment and you picture this traumatic event, how much do you believe that you're safe? And very often people will believe this positive cognition at a pretty low number. Our goal is to get them to a 7, I believe that the statement I am safe is valid. Then there's the desensitization and reprocessing part. So this is the bilateral stimulation, whether that's the eye movements, tapping or clicking. And they sell tools for this, so you don't have to always use your hands. They actually sell light bars, headsets that do a tone on each side, or you can just use your hands. So sets of 20 to 30 seconds where you're asking a person to just notice, see what comes up. At the end of the 20 to 30 seconds, the therapist would ask, so what came up? People say a couple things, that had been thoughts during that time, and okay, let's go with that. And then you do more of the bilateral stimulation. At some point, you get back to the original target, reassessing the subjective unit of distress and continuing to reprocess that memory until that distress level is as close to 0 as you can get for the day. Once you've gotten to a particular point, then you start to pair with the positive belief or thought. So now we've got the distress down. Now, can you replace the negative cognition with a new positive cognition that I'm safe, doing bilateral stimulation and assessing to see where they're at with how valid that cognition feels. A body scan and then closure of the session. Reevaluation would be the next session when you're coming back to see where are we at with each particular memory target. Some hypotheses about how EMDR works, and it is kind of hypothesis. I mean, there are studies that are showing a bit more evidence in particular directions, but it's still somewhat hypothetical. On one hand, actually many components of EMDR align with other therapeutic models. Thinking about the importance and significance of childhood trauma throughout the lifetime and how you view yourself. is very psychodynamic. The guided imagery and imagining, imagining exposure, and this kind of, granted it is an imagined exposure, it's not true exposure therapy, is similar to aspects of trauma-focused cognitive behavioral therapy. And the core beliefs and how that, shifts our interaction with the world and how we function in society is very much related to humanistic therapies. Shapiro and Maxwell, the founders of this and who have done most of the research on it, propose that the rhythmic bilateral stimulation is really the key here. That yes, all of those components are there, but that the bilateral stimulation is what makes this different. What they say is that bilateral stimulation causes a relaxation response in the body. That the stimulation activates an exploratory reflex that puts the human body into a state of alert. And then because you're in therapy, you realize that there's no real danger. So then your body can relax into the relaxation response that the bilateral stimulation also creates, which allows for reprocessing and integration of the memory. And by keeping this dual focus on both the traumatic memory and the rhythmic bilateral stimulation, you're activating an information processing. So allowing a person to make a new connection between this traumatic memory in a relaxed physiological state instead of that heightened physiological state. There are some studies that show that bilateral stimulation might mimic some of the physiological changes that are going on during REM sleep. And there have been studies that show that there are actually positive sleep alterations, improvement in sleep alterations in patients who have been undergoing EMDR versus those in a control group. There's another group of hypotheses around working memory, and their thought is that bilateral stimulation induces a demanding attentional task that causes our working memory to feel exhausted. So this dual focus might actually alter the quality of the storage of that memory, reducing both the intensity of the distress, reducing how vivid and emotional that memory actually is. So how effective is it? There's been, like I said in the beginning, a ton of studies that actually randomized controlled studies that show that it is extremely effective in treating post-traumatic stress disorder. Certainly it takes more sessions to resolve complex and multiple traumatic events, but for single trauma events, it can be a fairly rapid treatment. There are more and more studies that are being conducted that look at EMDR to treat things beyond post-traumatic stress disorder. So this article referenced several studies that it was a particular small feasibility study for looking at long-term depression and treating that with EMDR using the standard protocol. And while they cited other studies that have also looked at it for depression, show that it has some efficacy. With this particular one, 9 individuals fully engaged in the treatment protocols, 8 of which demonstrated clinically significant and reliable improvement in all depression measures. One person did say that their depression worsened, but attributed it to outside events and not the protocol itself. And what was stated in the article is that the EMDR therapist that there needs to be a careful assessment of the psychological resources and coping methods. This gets back to that preparation phase. So with somebody with a more complex presentation, you're going to need to spend more time in that preparation phase than maybe with other patients, because you need to make sure that they have some foundational coping skills and resources to rely upon. And looking at treating persons with a psychotic disorder diagnosis who also has PTSD symptoms, there have been a number of studies looking at this, which is good because we know that a high percentage of people who have psychosis also report having one or more traumatic life event. A 2012 study showed that after 6 90-minute EMDR sessions, patients showed significant improvement in their PTSD symptoms of depression, anxiety, some of their hallucinations, and self-esteem, and no adverse events. 2013, they compared prolonged exposure to EMDR in treating PTSD symptoms in patients with psychosis, and PTSD symptoms clearly decreased after the start of treatment, and most sustained the improvements over time. Symptoms of psychosis did increase in one patient, but for the prolonged exposure, but in none of the patients undergoing EMDR. A systematic review last year actually looked for studies that looked at using EMDR to actually treat psychotic symptoms, not just the PTSD symptoms of people with psychosis. And there was a number of them. So there was what they were able to show in those was a reduction in delusional symptoms and negative symptoms, that they saw no adverse events, but there was some mixed results in reduction of auditory hallucinations and paranoid thinking. Some of the studies showed that there was an improvement in that area, others didn't. Those studies that had longer follow-up periods were able to show that there's some preliminary evidence that EMDR could be beneficial for providing sustained recovery through both preventing relapse and readmissions, and provide some valuable insights into the wider impact that it can have on kind of the bigger picture recovery. So things like being able to return to and sustain employment. And although there's limited research on people using EMDR for people with psychosis, this early evidence shows that it could be not only a potentially beneficial, but also safe intervention. So in summary, EMDR is a highly specialized treatment protocol. My training was a week-long training, which included practice sessions and supervision, and then a 6-month window of practicing it with clients, another week-long training session that included supervision. So it's a fairly intense protocol, and I was EMDR basic level certified. So to get a higher level certification and be able to go on to supervise and teach others to do it is a whole different training protocol. There's multiple hypotheses about how EMDR works and what the real basis of it being an effective treatment model are, but there's sufficient data through high quality studies in the literature that demonstrate that it is at least as effective as other trauma-focused therapies in treating PTSD. And it often shows results in a much shorter period of time than many other trauma therapies, and might be better tolerated by many patients because outside of the history taking and assessment phase, there's less of the verbal processing, and people don't have to go through a huge narrative. And while narrative-based trauma therapies can be very effective for some, the idea of that is very off-putting to others. So this might be a method that's more tolerable. And because of the evidence that we're beginning to glean from other studies, EMDR should be considered at least suitable for nearly any mental distress associated with a traumatic event well beyond PTSD. So it might have far broader applications. And we know that trauma is connected to so many different mental health issues. Here's a list of resources, and